I invite Professor B.S. Goyal sir to take over for the next session, and we will send the results to the Secretary Dr. Yogesh Shukla in due course of time, and the competitive sessions, they will be announced by Dr. Shukla sir in the afternoon.
Thank you, Dr. Subhash.
So the next session starts with chairing by Dr. B.S. Goyal sir. He is a pediatric ophthalmology consultant at Tiwari Eye Hospital, Noida, and he has done his graduation, post-graduations, everything from AIMS, and he is a past president of SSI as well as GSI. The second chairing will be by Dr. Urmil Chawla from Rohtak with great oculoplasty interest along with the pediatric ophthalmology interest, and third chairing I'll be doing. Thank you so much.
Well, welcome. Am I audible? Am I audible?
Yes, sir.
Yes.
Yeah. Well, I think I should thank Dr. Shreyas for an excellent conference. I never thought that online conference could be as good as physical, though we miss informal interactions and dinners and the other things which are associated with a normal conference. Hope we are able to enjoy the hospitality next year with you or with anybody wherever the conference is. And it's after a long time that I am participating in a conference after almost a gap of about 2 to 3 years because I couldn't travel long distances at that time. Incidentally, I am recovering from COVID still and almost normal by now, and it happens to my birthday. And my birthday has been coinciding, thank you very much all of you, my birthday has been coinciding with, I think it has in the past coincided with 2 or 3 SPOCI conferences. The last I remember was in Coimbatore when I had cut a cake for everybody on the eve of the conference. Well, welcome you all. Let's go on to this. I welcome Dr. Urmil Chawla as the co-chairperson. I think we have 4 speakers in this. That includes one prominent Dr. Dadia on some genetic things where we like to interact. And then Dr. Urmil Chawla herself, Savleen Kaur and Sumita Agarkar. So I take this opportunity to invite Dr. Dadia to present his lecture on what we have learned from pedigree studies. I have had some experience long time back, which we'll share it after his lecture. Dr.
It is
Dadia, please.
Pedigree studies, sir. Not to do with genetics, but
yeah. Anyhow, whatever it is.
So, very good morning to one and all, and thank you, Chairman, sir. So basically, this Pediatric Eye Disease Investigator Group is a clinical network of pediatric optometrists and ophthalmologists, which is funded by National Eye Institute to conduct clinical research related to pediatric eye conditions. And basically, majority of the pediatric studies, they have focused on evaluating the comparative effectiveness of different amblyopia treatment regimens for children. And these studies, they are known as amblyopia treatment studies. And their results have dramatically changed amblyopia clinical practice pattern for many eye care providers. So basically, I am not going from 1 to 23, but relevantly. So first and foremost is regarding refractive correction. ATS 5, it was conducted with the aim to evaluate effectiveness of refractive correction in moderate amblyopia, and they concluded amblyopia resolved in 27% of the patients, and improvement of more than 2 lines was seen in 77% patients with refractive correction only. And in ATS 7, treatment of bilateral refractive amblyopia with spec corrections improved binocular visual acuity. So,
Can you make slideshow?
Yeah, your slide is not proceeding, sir.
it is slideshow only.
No, it's coming. You have to click that bottom, that slideshow.
No, you first click on, can you please click on enable editing there? Do you see enable editing on the top right in the
Yeah.
yellow bar?
Protected view.
Yeah, just say enable editing. Can you see that?
Yeah,
Yes,
That
please.
slide has come.
Now make it slideshow.
Yep.
is it?
Yeah, it is visible. Yes.
It's okay.
So, what is the clinical implication of this? So basically, it is reasonable to start amblyopia treatment with refractive correction alone for young children, and a follow-up after interval of 6 to 8 weeks until unless there is improvement in the amblyopic eye, the visual acuity is there. So basically, children still needs additional amblyopia treatment after improved visual acuity from an optical treatment effect. So basically, in some of the patients, child may not need additional amblyopia treatment beyond optical correction. So this is the one lesson which we have learned from these ATS. Then we have also some experience regarding one of the theses done at our center, and with refractive correction in our study, the improvement of more than 2 line was seen in only 16.67% of the patients. So then, whether should we go for penalization or occlusion? ATS 1 was conducted with the aim to compare patching versus atropine penalization for treatment of moderate amblyopia in 3 to 7 year of children, and they concluded both are appropriate modality for initial treatment of moderate amblyopia. So basically, what we have learned, atropine penalization is an effective alternate therapy in treatment of amblyopia. Then in ATS 4, they compared daily atropine versus weekend atropine in treatment of moderate amblyopia, and they concluded weekend atropine produces an improvement in visual acuity which is similar to daily atropine. Then in ATS 8, they compared weekend atropine augmented by plano lens with weekend atropine alone for moderate amblyopia, and they concluded augmentation of weekend atropine with plano lens does not substantially improve amblyopic eye acuity. Then ATS 9 was conducted to compare patching with atropine eye drops in treatment of moderate amblyopia, and they concluded atropine and patching achieves similar results among the children. So basically, what are the clinical implications? Atropine penalization has a similar effect as of 2 and 6 hours of prescribed patching. So it can be used as a first line amblyopia treatment or in patching failure cases. Daily atropine administration is not necessary. Twice week schedule is also effective, and there is no reason to believe that atropine need to be administered on weekend days, or it needs to be sequential. Weekend atropine penalization has also shown to be effective in treating both moderate and severe amblyopia. Then ATS 11 was conducted with the aim to evaluate combined patching and atropine for residual amblyopia, and it was concluded that visual acuity improved similarly in both the groups. That is suggestive that there is no additional benefit of combining treatment of patching with penalization in residual amblyopia. Then in ATS 13, non-randomized prospective trial of glasses alone for strabismic and anisometropic amblyopia was conducted, and treatment effect was greater for strabismic amblyopia. Then ATS 16 was conducted, is being conducted regarding implementation of atropine treatment for amblyopia, the effectiveness of adding a plano lens, and the results are not published. Then what are the drawbacks of ATS? We have to keep in mind limitations of ATS. The strict inclusion criteria hampered the study by including a limited number of the patients. Methodology was not strict, thereby making the results subject to many variations. Ethnic variation on treatment always remain a factor. And another question is atropine safe in tropical countries? And compliance was not monitored. Then there is no shortcut or substitute for occlusion treatment in amblyopia. However, variability exists in number of hours prescribed to treat amblyopic patients. Then duration of patching was compared in ATS 2A and 2B. In ATS 2A, full-time patching was compared with 6 hours of patching in severe amblyopia, and they concluded there is similar improvement in both the groups. And in ATS 2B, 2 hours patching was compared with 6 hours patching in moderate amblyopia, and they concluded there is similar improvement in both the groups. It was noted that prescribing greater hours of patching did not seem to have a significant beneficial effect in first 4 months of the treatment. So what are the clinical implications? Full-time patching is not always needed for a successful treatment outcome. Prescribing lesser amount of patching may promote better overall compliance with treatment. When patching is prescribed, it is reasonable to prescribe 2 hours of daily patching for moderate amblyopia and 6 hours of daily patching for severe amblyopia. Some children with severe amblyopia will respond to as little as 2 hours of patching. There is no consensus over duration of patching, and different authors have recommended different duration of patching. Full-time occlusion have been supported by many authors in the past. However, the popularity it commands among clinicians is not always shared by patients and their parents. And major failure to therapy is because of the poor compliance, and hence recent trends are in favor of part-time occlusion. Then is age a bar to treat amblyopia? ATS 3 was conducted whether amblyopia can be successfully treated in older age children, that is 10 to 18 year of children, and they concluded treatment can improve visual acuity in older children also. It is basically amblyopia can be treated in adults because regardless of person's age, it is the visual system which consists of eyes, brain, and visual pathway that can be retrained, and visual skill that needs to be retrained is binocular vision. Recurrence of amblyopia clinical implication is because a majority of the recurrence in children occurs in less than 8 years of children within 3 months after cessation of the treatment. So early follow-up is very critical, and we should not abruptly stop the occlusion treatment. Then in ATS 6 near visual activities, they were ATS 6 was conducted with the aim to determine whether performing near activities while patching for amblyopia enhances improvement in visual acuity. They concluded performing common near activities does not improve visual outcome in treatment of amblyopia. However, there are a lot of other studies which are contrary to recommendation of ATS 6. Then ATS 14 was conducted with a pilot study of levodopa as treatment for residual amblyopia, and results suggested that levodopa carbidopa for residual amblyopia in older children and teenagers is well tolerated. And then ATS 17 was conducted with aim to compare the efficacy and safety of oral levodopa and patching versus oral placebo and patching at 18 weeks. And they concluded that oral levodopa while continuing to patch for 2 hours daily dose does not produce a clinically or statistically meaningful improvement in visual acuity compared to placebo and patching. So we have also done a study regarding role of levodopa, and we concluded that levodopa significantly improve visual acuity and effect is more pronounced in children who are younger than 8 years, and it reduces the latent period. Effect is maintained till 6 months, and it has to be used only as an adjuvant therapy. Then ATS 18 was done with the aim to compare effectiveness of 1 hour daily binocular games per day per week with 2 hours daily patching for 7 days per week, and they concluded binocular eye pad treatment was not as good as 2 hours of prescribed daily patching. Then this amblyopia treatment study 18 is broken into 2 arms, and one is non-inferiority study and one superiority study they are being conducted. Then ATS 19 is being conducted regarding role of excimer laser surgery for anisometropic amblyopia. It is ongoing study. We have also conducted study regarding role of
The link is gone.
Voice has gone.
I think sir's net has gone slow. What do you think, Sai and Nipam?
Internet issue, madam.
Yeah.
I think it's an internet issue from their side because we are able to hear each other all right.
Yes.
So we'll wait for them to get the internet connection back.
By the time we are waiting, we can have some comments from Professor B.S. Goel.
I think we can label Dr. Dadia as an amblyopia expert. And I appreciate the amount of work he has presented. And he has rightly said, but there is a little difference with him. What I observed a long time back was that the accommodation is slightly weaker in cases of amblyopia, and near work does stimulate and accelerates the improvement in amblyopia. I would wish that he studies this aspect as well, because we had studied accommodation in amblyopic and non-amblyopic patients and found a great difference in them. But nevertheless, the occlusion and patching remains still the par excellence, and you may decide the time, the amount of patching depending upon an individual. I think it has to be dose regulated by the child's response and the patient's acceptance. But the earlier the larger amount of patching done would be better. And incidentally, my topic for PhD was amblyopia, done almost about 40 years ago. And some of the things which I had studied at that time are trying to be proved correct at this time now. That included even meridional amblyopia, some brain studies in the monkeys and cats, and so on and so forth. It's no point repeating them at this time. We need more attention to treatment of amblyopia so that we can check children's visual acuity at the earliest. Dr. Chawla, you have some comments to make?
Actually, sir, your observations clearly tell us that the clinical science and the basic science changes very slowly. It develops slowly. The rapid advancement has been in technology.
Yeah.
Yes, ma'am.
ATS studies have studied so many aspects of therapy of amblyopia, but finally you see all of them minutely. Subhash has presented them in a very exhaustive way. But if you look at the summary, we come back to the thing that occlusion remains the mainstay. The others are adjunctive therapies. And as far as the duration of amblyopia is concerned, one of the ATS studies also talks of 2 hours patching being equivalent to 6 hours patching. That is the recommendation only for moderate amblyopias, not for severe amblyopias. So as Dr. B.S. Goel has rightly said, we have to kind of monitor our patients in their own settings, and depending upon their compliance, we have to tailor the dose.
But certainly, madam, 4 hours patching would certainly be better than 2 hours patching, though we
That is what-
cannot compare the individuals. It
Yes.
may be enough for 2 hours in one individual. It may require 6 hours depending upon the type of amblyopia and an extent of amblyopia.
Yes,
And
that is exactly what
perhaps
I was
many
saying.
of you may not be aware that at one time Kappers and Bangalter's method were so popular that every hospital was admitting patients. They became little out of fashion completely, and amblyopia became the anchor sheet for treatment by patching and miscellaneous use of glasses and correction of refractive errors. Any
Urmil,
comments, Dr.
Uh,
Pradeep?
Yes, ma'am. Actually, even I conclude that the treatment of amblyopia is a job, frankly speaking, easier said than done. It is very easy to advise the treatment, but as far as the compliance is concerned, it is really difficult task. And when you really face this problem in a very close relative of yours or a very close person, you really realize the practical problems which the parents face. And part-time occlusion is definitely as far as compliance is concerned, it gives better
It's
result
better,
than
yes.
full-time occlusion. And like one cannot be definitely full-time is better. As Dr. Goyal said, 6 hours is always better than 4 hours. But being greedy for that and losing that 4 hours also is a thing we have to weigh the pros and cons. So I have seen that part-time occlusion gives a definitely good result. So we should go for it. There is no harm in patience on the part of parents as well as the doctor is very important. This is what I feel.
Well, about
and
the
patients,
oral treatment, I have had no personal experience about oral treatment. I never tried it myself. But the reports say, does it really hold ground for future? Because during the past 10, 15 years, it hasn't made any progress in suitability of the oral treatment. If the oral treatment was to come, I think it would have been really a revolution.
Sir, we had done study in 300 children for oral treatment, and what we found is that was not much of a difference. I still go for patching is the best thing.
Patching is the
And as
best, no doubt.
Dr. Urmil said, it's a part-time patching. I'll definitely say because just child should not have a mental trauma when they're
Yeah.
patching and going to school. But
Actually,
Dr. Goel said
when-
6 hours is necessary.
whenever I
Yes, it is
feel
4 hours. Thank you so much.
Hello,
Whenever
Dr. Shreya.
In one of the conferences, I remember Pradeep Sharma had been trying some neurotransmitters
Yes.
treatment. What does he say about it now? What is the report at this time?
Good morning, sir. Goel sir, very good morning.
Oh, good morning, sir.
Sir, कैसे हैं
I
आप?
have been seeing you since yesterday.
अरे सर,
I had an opportunity to speak only today.
आपकी तबीयत कैसी है? आपको कोरोना हो गया था?
अब ठीक है बिल्कुल, fine. I
Sir
am
को
very
birthday
fine.
wish कीजिए sir.
Oh, very happy birthday, sir. Very happy birthday. आपको
And it
बहुत-बहुत
coincides
मुबारक हो.
almost every time with the SPOSI conference.
Yes. सर, मैं एक छोटी सी बात ऐड करना चाहता हूँ कि नाउ द रिसेंट ट्रेंड, ये सिटिकोलिन और एल-टोपोपा तो सब पुराने हो गए. अभी जो न्यूरोट्रांसमीटर्स की आपने बात करी, देयर आर टू very good neurotransmitters which have been in America. They have been approved by this thing. एक तो GABA है. And
Gabapentin, yes. I meant gabapentin.
Yes, और एक और मैं नाम भूल गया उसका, एक और न्यूरोट्रांसमीटर है which help in the synaptic to accelerate the synapses and to accelerate and rejuvenate the neurons. तो GABA और एसिटाइलकोलिन का जो था वो इसके एक वो ड्रग आ गया, मैं नाम भूल गया उसका. These two drugs are now being tried as a neurotransmitter directly given as oral and as an IV to stimulate and rejuvenate the
brain cells.
हाँ सर, ये अभी इंडिया में तो नहीं आया है, but they are trying in USA.
I think Dr. Urmil Chawla is supposed to be talking on
Yeah. Pharma. Yes sir.
Well,
So I think, sir,
You have some observation on gabapentin?
Dr. Shreya, just to take,
Just
just
a
to
minute
take,
before she starts.
Yes.
Pradeep Sharma?
Yes. No, gabapentin, I think, doesn't have much of role. GABAergic pathways are what they are talking about. And these drugs,
True,
whether
sir.
levodopa or citicoline, they are working through the same pathway.
Yes.
Gabapentin, as such, is not been the drug of trial.
True, sir.
No,
Not,
but it is again coming into vogue now. It is again coming. They are trying again because इनका pathway अलग-अलग है प्रदीप जी. ये
well, our next topic is pharmacological agents in amblyopia. We can discuss the rest part after Dr.
yes,
Chawla's
yes,
lecture.
yes.
We have started this discussion earlier than what she is to say. Well, Dr. Urmil Chawla,
Yes,
invite
sir.
you
Can I start?
for your lecture.
yeah, before we go there, because it has been too much of a technical discussion, can I just share my screen real quick? And
Who is speaking?
this is Nipam on behalf of Drashti Netralaya.
Thank you very much, all of you.
Sir.
Let's
Should I
wish
share my screen?
Dr. Goel happy birthday.
Okay.
Yeah, thank you very much.
Many, many happy returns of the day.
आप
happy
पहले
birthday,
बोलते
sir.
सर
Happy birthday.
आप पहले बोलते तो केक भी वर्चुअली कटवा देते आपसे.
केक हर साल स्पोसी कॉन्फ्रेंस में काटा है मैंने.
खा लेंगे ना.
मैं यही
हम
तो
सब
याद
अपने
कर रहा
अपने घर
हूँ.
काट के खा लेंगे. डॉक्टर बी
कोयम्बटूर में पूल साइड पे केक काटा है. 12th of December is my birthday actually.
नहीं, आपको केक दिखा के और हम आपके नाम से काट के खा लेते हैं.
And after
कर लेते हैं.
COVID, my
अगर आप
son
बोलो तो
brought
अभी केक
cake
दिखा
today.
देते हैं. और क्या कर सकते हैं सर?
मैंने
My
बोल
son
दिया हम
brought
कैसे
me
खाएं.
cake today.
अच्छा प्लीज कैरी ऑन यार प्लीज.
Anyhow,
आपकी
Dr.
शेरवानी
Chawla.
बहुत अच्छी है सर आज गोयल साहब.
I think we are running short of time. Please.
Yeah, please.
Yeah, Dr. Chawla, please.
Yes, sir. Please, may I share the screen? Good afternoon, one and all. And I just continuing in this basic strabismus session, a basic topic, and continuing further with where Dr. Dadia had started the conversation. My topic is role of pharmacological agents for treatment of amblyopia. Am I audible?
Yes, yes.
Yes.
So amblyopia, as we know, is a sleepy eye or a lazy eye. It is not a dead eye with dead brain connection. The connections are just lying dormant and we need to just activate them. The most common cause of preventable blindness with prevalence of 1 to 5% and being treatable is the reason why we want to treat it. The goal of treatment is to restore and improve the visual acuity by two strategies. First is to either we present a clear retinal image to the amblyopic eye, and that can be done by eliminating the causes of visual deprivation or correcting the various refractive errors, or compel the child to use the amblyopic eye. And the recommended treatments have to be based on the patient's age, the visual acuity, compliance with previous treatment, and physical, social, and psychological status. A perfect amblyopia therapy should be effective with good compliance, acceptable to the patients and parents, quick in action, safe to use, easy to administer, cost effective, and well maintained. The choices of treatment are used alone or in combination to achieve the goal of treatment. It could be a passive therapy where the patient experiences a change in visual stimulation without any conscious effort, which could be proper refractive correction, occlusion, or penalization. Or it could be an active therapy like pleoptics, near activities, syntonic phototherapy, role of perceptual learning, and pharmacological therapy, which I would go ahead. The limitations of present treatments are the presence of residual amblyopia, which is left, poor compliance to patching, the recurrence of amblyopia, poor effect in older children, and it does not address the deficits in binocular system. So comes the role of pharmacological agents in amblyopia. First, talking about penalization, it is a therapeutic technique performed by optically defocusing the eye, and it can be done either pharmacological penalization or optical penalization. The indications are patients who are not compliant to occlusion, mild degree of amblyopia, maintenance after occlusion, and isometropic amblyopia. The pharmacological penalization, it is an effective method of treatment for mild to moderate amblyopia in children. 1 drop of 1% atropine is instilled daily in the good eye. Weekly instillation is effective for mild amblyopia, and it provides sufficient blur to force the child to use amblyopic eye for near and good eye for distance advantages and does not totally disrupt the binocular vision. Cyclopentolate can be used in an office test to predict whether penalization will work or not. And in this, that we provide them myopia eye with full optical correction while deadening the sound eye with cyclopentolate and removing the optical correction from the sound eye. If the patient switches to the myopic eye under these conditions, the patient will definitely improve with atropine penalization, and we can go ahead with it. It can be done as near penalization, where the fixing eye is atropinized and fully corrected for distance, while the myopic eye is overcorrected with +2 or +3 diopter. It could be a distance penalization, where the fixing eye is atropinized and overcorrected, and the myopic eye is fully corrected. While in total penalization, the fixing eye is atropinized and undercorrected, and the myopic eye is fully corrected. So these methods of penalization we can follow. And as Dr. Dadia covered these PDIC studies in ATS1, it showed that atropine and patching are equally effective as primary treatment for moderate amblyopia. ATS4 told that weekend and daily atropine can produce similar improvement for moderate amblyopia. However, the advantages are cheap and better compliance, but it definitely has side effects of the drugs, risk of occlusion amblyopia, as their systemic absorption can be there, and it doesn't work well in myopic patients. And unless penalization decreases the visual acuity of dominant eye below the myopic eye, this form of treatment is not advised. So we have to confirm this in the very beginning. Coming to other pharmacological drugs, history dates back that these drugs have been tried substances, these oxygen, strychnine, alcohol, propranolol, picosulin, and exogenous nerve growth factor. However, none were successful in terms of clinical applicability and effectiveness. Levodopa and carbidopa combination, as Dr. Goel was saying, Kasamatsu and Pettigrew in an animal study showed that even older amblyopic animals could cover some function if their brain is flooded with dopaminergic drugs. And dopamine has been known to play an important role in retinal function and in central visual processing. However, it cannot be administered as such since it is unable to cross the blood-brain barrier. Therefore, the need of this combination is there. It is a precursor of levodopa is a precursor of dopamine, and it easily crosses the blood-brain barrier. Carbidopa is a peripheral decarboxylase inhibitor which prevents the peripheral conversion of levodopa to dopamine, and hence it increases the availability of levodopa in the CNS and allows for reduction in the dose by about 75%. An RCT conducted in 2015, however, because literature shows mixed opinion, it showed that for children in 7 to 12 years of age with residual amblyopia, after patching therapy, oral levodopa while continuing to patch 2 hours daily, it does not produce a clinically or statistically meaningful improvement in visual acuity compared with placebo and patching. Another Spilett study conducted showed that the visual acuity after this combination temporarily improved in amblyopic eyes, but the improvement in visual function started to decrease 5 hours after the drug ingestion. So this was a little problematic. There are a number of other studies conducted by Oj et al. In 2015. He concluded that oral levodopa can be of benefit in the treatment of amblyopia in older age group patients. Repka et al. Said that oral levodopa is equivalent with patching provides no additional benefit over the placebo therapy. Kothari et al. Said that oral levodopa should be combined with occlusion therapy only for residual amblyopias. Rashid et al. Concluded that levodopa may be added to the occlusion therapy for good result. As Dr. Dadia just mentioned, in a study conducted in 2009, they concluded that improvement in visual acuity with levodopa is maintained, especially in patients younger than 8 years of age group. Mohan et al. Concluded that addition of full-time occlusion therapy to levodopa helps to maintain visual acuity for a longer period compared to levodopa alone combined with part-time occlusion. And View et al. Concluded that levodopa is a safe and effective drug for improving visual acuity functions in children with refractory amblyopia. So, as far as the dosage is concerned, it is usually administered along with carbidopa in a 4:1 dose ratio, oral tablet or as oral suspension. Liquid suspensions have been shown to be stable for around 28 days when stored at 25 degrees. The drug is bitter in taste, so needs a protein drink along with it. And however, it is well tolerated in children. The dosage is kept around 0.5 to 0.76 of levodopa plus carbidopa of 0.17 milligram per kg body weight. 3 times a day it should be given. And oral dosing should be less than 1.02 milligram per kg body weight 3 times daily to prevent any change in body temperature, which is known if more than this dose is given. However, it has limitations of side effects like headache, nausea, dry mouth, abdominal cramp. Treatment remains controversial as visual acuity improvement has been relatively small, not clearly better than patching alone, and there are questions regarding the long-term stability of vision. Coming to the next drug, the citicoline, it is an intermediate byproduct involved in the biosynthesis of cell membrane phospholipids. It gets degraded into its constituents of cytidine and choline. It once absorbed crosses the blood-brain barrier and gets incorporated into the cell membrane phospholipids. Campos et al. Also reported a statistically significant improvement in visual acuity following treatment with citicoline. It is given as a dose of 1000 milligram intramuscularly for 15 days daily in older children and found that significant visual improvement occurred in both emblyopic eye and sound eye, which remained stable for at least 4 months after stopping the treatment. The dose is kept as 7 to 28 milligram per kg body weight. But the limitation main is that there are lack of well-defined RCTs proving its effect. There are some drugs which are being experimented. Donepezil is one of the drugs. The study is continuing to study its effect on residual amblyopia in patients 8 years of age. The results are expected soon, somewhere this month only. Now, the latest in the armamentarium of treatment of pharmacological drugs are the omega fatty acids. Study on these has been done, and it has concluded that they improve visual acuity in patients with amblyopia and maintain improved visual acuity, but there is no additional benefit when compared to patching alone. But further research on this should be done, and they may prove out to be of some help. DHA study is also continuing right now, and the results are expected somewhere next year. So let's see how it comes out to be. So to conclude, I would say that the inadequacy of conventional occlusion treatment therapy and non-compliance of patients led to an insight into the role of pharmacological therapy for the management of amblyopia. Although occlusion of the dominant eye is the best treatment modality for amblyopia, its efficacy decreases with age, and so the need for alternative methods. Various studies have shown improvement in visual acuity and VEP amplitudes with these pharmacological agents. And levodopa may be considered as an adjunct to conventional occlusion therapy in cases with residual amblyopia and also in the older age group. And regression of effect after stoppage of therapy in occlusion amblyopia in younger patients remain a matter of concern. And further studies are therefore needed to evaluate the full efficacy and side effect profile, and also to find out new pharmacological agents which can be helpful for the treatment. Thank you so much for the patient.
Thank you, Dr. Urmil. I think it was a nice presentation.
Thank you, sir.
I have a small comment to make. Well, so far we have been with lectures that by far the patching is the excellent method. But if the patching has not been possible, alternatively penalization may be tried, but it wouldn't be as effective as patching. One should always remember that it will not be an alternative to patching. It will be only a small addition that the amblyopia can be prevented or treated. And by far, the amblyopia treatment still remains a bugbear. Many children do improve, they cannot follow it up, then patching stops and then it comes back, squint is operated. One observation, I don't know if one of you have it, that where patching is not possible, we certainly do a penalization. Will an early surgery restoring alignment will help in improving the vision? That is number one. The second observation which we had made earlier was that when we did a keratoplasty in one-eyed patients, the vision improved far more quicker than in those who had a normal other eye. That shows the role of patching, which is really significantly positive. Any comments about this thing by anybody? Subhash?
Sir, I think patching is going to stay, and
yeah.
So patching is the pivotal point for amblyopia, and it is going to be there.
Patching is going to stay because I don't think we can find an alternative. Any role of early surgery by any one of you, that where patching is not possible, we align the eyes and
Sir,
then give a binocular stimulus to improve the vision.
Yeah,
For
you are
some time.
absolutely
I have
correct, sir.
observation on two
You are
patients,
absolutely
sir.
correct, because early surgery will definitely help for early binocular development.
Yeah, that's the
And
point.
once the binocular develops, then many other visual deficits also develops gradually. That is my observation, and I'm happy with early surgery also, where the patching is very difficult.
Well, your
I
games are
also,
quite popular with
I
children,
also,
but are they
Yeah,
as
yeah,
effective as patching? That's the
yeah,
point.
they are, especially in all these high-risk babies. These
Anyhow,
visual games after the
thank you
age of
very
2
much, all of
years,
you.
sir,
the
Let's,
restricted time.
I want to share, sir.
yeah, exactly. Yes.
I have observation. If I could recall, at least two patients I remember that, and one of them had happened to be a doctor's daughter. So these patients were not complying, very much compliant for occlusion therapy, and they were not improving very nicely with occlusion therapy. So I tried on them corrective prisms.
Try
Corrective prism along with the
correcting
refractive
squint. Yes, yes.
and
That's
the
what I
corrective
put
prism,
a proposal.
and yes, and because you see the corrective prism ensures bifoveal or at least the foveal stimulation of the squinting eye, and these patients who were earlier not improving in vision, they improved with prism therapy.
It may be worth a trial.
Yes.
So I think that if occlusion is not working or there is no compliance, penalization of course may work in some patients, but early surgery can be considered.
Well, thank you very much.
Dr.
Urmil
Sumita
Chawla,
wants to say something. Dr. Sumita.
Yeah.
I'm going to take a slightly contrarian view here, because vision is the driving engine for binocularity. If vision is poor, surgery will not help. And they almost always tend to go for consecutive exo or ESO, whatever, depending on the alignment is never stable. One.
And if the patient is not at all compliant,
Regarding
I don't think.
Yeah, Dr. Vinita Singh's suggestion about prisms. I think prisms, probably if it's a small angle, you can do it. But if it's
Only
very
in
large,
small angle.
Yes,
It is akin to surgery in large angle squints. Yes.
Yeah, but that is you when you put 45 prisms, you are going to
No. We are talking of a small angle in this particular child that I'm talking of.
I think we'll come to the next speaker. May I request Urmil Chawla to call the next speaker?
Yes, sir. 1 minute.
Savleen Kaur.
I request Dr. Savleen Kaur. Everybody knows her. She's from PGI Chandigarh, a very young, energetic, and vibrant SPOSI member. I invite you. I think your topic was on imaging in strabismus.
For Chandigarh, I remember I was once selected for the post of assistant professor to beginning of my career, but somehow I didn't join. So I missed Chandigarh life completely. I continued to stay in Aligarh.
Closer to us.
It was during the time of Dr. Jain when he selected me and invited me to join the faculty, but I couldn't somehow.
Can we stick to time, because Dr. Shukla sir is repeatedly telling me be strict, and the thing is going so late. We can discuss in chat also.
Good morning, everyone. Thank you, Dr. Goel. I think PGI's loss that you were not here. So since we're talking about imaging, and we have already spoken about amblyopia, so I would be talking a little bit about the basic pathogenesis, because that's where I think imaging is now helping us, and some points where clinical examination can be complemented with these newer imaging technologies. So to the hands of a pediatric ophthalmologist, I think we have a lot of imaging modalities available, and it will be unfair if I start speaking about all of them. So I'm going to talk about some of my favorite ones. And since we have talked about amblyopia, I would begin with that first. So the optical coherence angiography tomography, that is the OCTA, that is now a budding investigation in the retina field. To us, it has been used in amblyopia because it has been used to establish the retinal functional changes, because we were always talking about the neurological aspects of amblyopia and how it has been caused. But now that we have these imaging modalities, we are trying to see whether the retinal function is also normal in these patients. There have been a lot of studies that have come up with the OCTA in all types of amblyopia. Just in brief, this is how an OCTA image looks like. And the first study reported that there is a macular vascular density decreased in patients who have amblyopia. The foveal avascular zone was also reported to be enlarged. And also the optic disc did not have the normal perfusion vis-a-vis a normal fellow eye and also control eyes. So we tried to do the same thing, and we saw that when we tried to image OCTA in patients of anisometropic amblyopia as well as strabismic amblyopia, this is how a normal vessel density would look like, and their vessel density at the superficial and the deep layer was reduced, and the choriocapillary network was also attenuated. So there were different areas where the flow was actually low compared to a normal fellow eye. So we concluded that the pathogenesis of amblyopia might be involving the choriocapillaries, which is the primary blood supply for the photoreceptors. So now we do know that we do have these deficits in patients who have unilateral as well as bilateral amblyopia. The contralateral eye can also not be considered equivalent, so that is a drawback of all these studies. We do document these vascularization defects, but we do not know whether they are causative for amblyopia or is it because of amblyopia that we see these defects. So the cause-effect relationship cannot be established. We cannot use this at present with the evidence available as marker of neuronal maturity. Whether OCTA changes would be reversed, we would see with times to come whether amblyopia treatment changes these changes seen on the OCTA. Nevertheless, it's a useful modality and can be used to establish and further study the basic pathogenesis of amblyopia. The second imaging modality, that's kind of my favorite, the UBM and the ASOCT. Again, in cases where, for example, this one, you have an exotropia in a country like ours where you might not have an electronic medical record system at many places, you might not have the previous surgical records. You do see the photographs and diagnose the patient as consecutive exotropia, but you have to still decide how much surgery to do. So obviously you decide it on table, you want to explore and see where the muscles are, but the UBM to my mind can make your planning a little better, can cause a little bit less of scarring because you are not fishing too much for the muscle. So a normal UBM will tell you the muscle morphology from the limbus. You can see it between the limbus is identified first, and then you go back and try to image the muscle, which is seen as the hypoechoic band. And once you see the muscle, you can measure it with the help of this inbuilt caliper in the machine. You can see resected muscles. With experience, we come to know whether it's a pseudo tendon because it is not a continuous band. And in some cases, you can actually see whether the muscle is not seen within 10 to 14 mm of the limbus, and then you can plan a transposition surgery maybe. So in resurgeries, it is a little more difficult. The accuracy to 1 mm, if you get that, I think you will call it I would call it a success that you have accurately identified the muscle within 1 mm, because often you see a lot of scarring and you have to do it. You need the help of experienced technicians also in order to image the muscle. So in this patient, once we did the UBM, we saw that the medial rectus was at 10.8 mm. So we advanced the medial rectus to the original insertion, and we got a good, successful post-operative result. We did establish and we did publish one of the theses of our residents, Dr. Namita, that UBM is efficacious when you do not have a surgery done, and in cases where you think you're doing it post-operatively, the accuracy goes down to say about 78% for the medial and 50% for the lateral rectus. In plications, often not in the early postoperative period, you can see this double shadow, and you can actually measure the amount of plication as twice the length of this double shadow, which again we published that plication, although similar to the resection in quantitative terms, you can image it, so it might give you an advantage. Where would I need a UBM? I would say in cases where I always like to do it is facial asymmetry, craniosynostosis, or where I know there is trauma and I can expect abnormal muscle. So I'm more sure whether when I go to the operating room. Of course, the gold standard is when I see the muscle on the table. In case of resurgeries, I like to do these modalities because I am lucky that I have access to both of these. And it might not be very reliable in patients who have undergone very large recessions. The measurements can be really, really off the mark. In children and uncooperative patients, here is where the second modality comes, that is the ASOCT, which is non-contact. It's better, it's clearer, and we are in the process of publishing it. We did publish our views in JAPOs, and now I think it does give a good accuracy in resurgeries also, despite being non-contact method, and better delineation for scar and migrated muscles. Any talk in strabismus is incomplete if we do not talk about neuroimaging. We all know neuroimaging can be indispensable and has been used for decades. Few instances where I feel neuroimaging really helps is that this patient referred for an upgaze limitation, actually diagnosed as a monocular elevation deficit. But if we see carefully, he did seem to have a little bit of proptosis and a lid change also. So I ordered a neuroimaging and before doing anything else, and it was an optic nerve glioma that we picked. A case of abnormal eye movements I would like to share, where the mother kept on saying that one eye moves, and my residents felt that there is nothing abnormal with the child. But when we carefully looked at, there was nystagmus in actually one eye. If you see carefully, a small upward drift seen in this patient. And after a little bit of more examination, this upward drift, along with that, because it was uniocular, we let the mother tell us when the child has nystagmus, and we let him photograph us. We saw this head bobbing also along with that. So in these cases, I think with nystagmus, head bobbing, and torticollis, sometimes the diagnosis is quite clear. So spasm mutans, MRI was normal, but we knew that we had to order an MRI straight away. So neuroimaging in the first visit in children, when do you order that? You should not do it always. Obviously, in a country like ours, there are cost constraints. So if you have systemic signs, you have lid changes or globe displacements, abnormal asymmetric new movement disturbances, or of course, we have suspected intraocular masses and disc edemas. Those are the indications that, to my mind, we can order neuroimaging even in the first visit for children, and then hold on after a clinical opinion. To conclude, there is no technology that is perfect in every setting. We often have limitations. We do not have the right staff. We do not have the right machines. We do not have cooperative patients because we are all pediatric ophthalmologists. We need to develop thoughtful testing strategy to minimize cost also, not order unnecessary investigations as well. We can use the most sophisticated instrument available with us, but not without a thorough clinical examination. Thank you very much. I would like to acknowledge Dr. Jaspreet, who has been giving inputs on almost all of my studies. Thank you very much.
Thank you, Sablin, for giving new ideas. But would you recommend UBM for all cases or only in limited cases where you expect structural abnormalities in the muscles?
I do not order them in all cases, sir, even if I have access. Yes.
Because one of the statements I thought that it will be useful to do in every surgery before every surgery. I don't think it would be really recommended.
In resurgeries, I do it because I have
resurgeries is all right. Resurgeries
not
and
in all, sir. No,
yes.
No, sir. Not in primary surgeries. I think
because you have to modify your surgical procedures once you open up the muscles and
only
then decide what you have to do.
So only in resurgeries. And
any other comments? Any other comments? Because I think
nowadays we have some more additions which are coming. One is the dynamic MRI, which we can do in different gazes that will help in the aberrant innervations. Then we have the AOSLO. That is another new technology with the help of Voronoi tiles. We have recently completed that study and maybe we are sending it for publication in cases of ametropic amblyopia. In anisometropic amblyopia, obviously these imaging is not showing much of result. There are variables. But in that, it's an interesting thing that we're getting. fMRI is another diagnostic tool for amblyopias. So I think these, and CCDDs, we have the high definition MRIs, which we have published in cases of Duane's, Mobius, and CFUMs.
We may be wiser in the next conference, Dr. Pradeep.
Yeah.
Yeah, right.
In publication, yeah.
Yeah. Then may I invite the next, Dr. Sumita Agarkar? Please.
Dr.
Sumita?
Yes, sir. Thank you, sir. Thank you for inviting me. Happy birthday to Dr.
Thank you very much. Thank you.
So I'm going to talk about not just refraction in children, but difficult situation for refractions in children. And thank you, Dr. Shreya, for this opportunity. So when we are interviewing the kids for fellowship, and when they tell me that they love children, I usually show them this video. And a lot of them do have second thoughts about their career choices after that. And so among all children, probably the most difficult but still doable are the infants, children with special needs or special children. Post-trauma, sometimes you need a little bit of more patience. Subluxettal lenses and keratoconus, a lot of times we don't pay enough attention to the refraction part of it, and really a little bit trigger happy when it comes to advising surgery in these two situations. So coming to infants, it's really challenging in pre-verbal children. And here probably you have to pay attention to the fixing pattern, pupillary right reflexes and visual behavior. That provides more information than actually anything else. Dr. Mihir Kothari's study on fixation preference is being very specific, but poor vision is very, very important piece of evidence there. And when you are looking at fixation pattern, it's also important to know how and follows the light. If you can see, this child who has is amblyopic in the right eye, but has relatively good vision, actually follows light with her eyes only, and you don't see that much movement of the head or anything she is fixing. So she has probably relatively good vision compared to this child who has a persistent RD despite ROP surgery. And you can see it's only the head which tracks the light and not really the eyes. So that gives you an idea about, in very, very small infants, about how vision might be. Children with poor vision often only follow using their head and not the eyes. Again, resistance to occluding one eye is also an indicator for how an infant might have, whether she has equal, or he or she has equal vision, or and VEP is a good response, but often in infants it is not very reliable. And while a good VEP is a good backup or good feeling, but bad VEP does not necessarily indicate poor vision, and that must be kept in mind, especially when you are doing a VEP in children who are younger than 1 year. So as I said, other visual acuity methods like CARDAVE or Taylor cards can be available. If they are available with you, they often provide quantitative information, though they are expensive and have their own limitations in terms of cooperation and attentiveness of the child. And often subjective visual assessment often gives you better clue than instrument-based screening like VEP or a photo screener. But this is a Taylor chart, and you can see it gives you a little bit idea about grating acuity, and depending on the grating size used, the observer is behind and through the pinhole, and you look at the child whether she is looking at the pattern, and the grating which we are used gives you some kind of quantitative analysis. But again, as you can see, limitations are straight away that child has to be attentive, looking, cooperative, not upset, not hungry, all those things to make a reliable assessment about the vision of this child. Lear paddles again can be used in very small children, and looking at the tracking, and again this gives you a quantitative analysis of vision in very, very young babies in cycles per minute. And again, this can be done initially bilaterally, and then you can check it unilaterally also. The principle remains same. The child will look at a patterned object, more likely to look at a patterned object. It's a preferential looking test. Now coming to the refraction, practically when you're dealing with infants, it is just a quick screening to see if the baby has a very high plus or high minus, which requires prescription. We are really not looking at refining it to the last 0.5 cylinder. Dilatation definitely helps, and your own retinoscopy helps it's very useful rather than asking your optometrist to do it. Brightness of reflex also gives an indication about the refractive error. Sometimes dull reflex can indicate a very high plus or a very high minus. And in that case, you really need not go from 1.5 to 2 and 3.5. You can probably straight away put +8 and -8 and to see how it is giving. So these are practical tips about doing refraction in very young babies. There are several prescription guidelines available, and they help you decide. In fact, AIOS has come up with a very, very practical guidelines for our children here, and it can give you an idea about whether the prescription has to be done or not. But also it's important to guide parents on frames, especially in infants, because infants often do not have a nose bone which is developed, and a poorly fitting glass is the main reason why they will not wear glasses, rather than your available American Academy, but you can use any one of, even AIOS guideline is very good. Second important or difficult refraction is aphakia. Again, bilateral aphakics do very well with glasses, and I have really no objection to treating bilateral aphakics with glasses. If you can fit with contact lens, very good. But if you don't, then you can give the glasses as early as in the first week of the surgery. When you are dealing with infants less than 6 months, I think it is a good idea to prescribe a near correction rather than distance correction or bifocal glasses. And once the children become 1 year or more, you can give them an intermediate correction with say 1.5 ad. Don't worry about small cylinders. Again, here design of frame is very, very important. Bifocals, usually I start when they are ready for school. Unilateral aphakics, probably you should push for contact lens, and that to RGP. But if patients are not willing, not unable to take care of contact lens, please go ahead and give the glasses. Children tolerate anisoconium much better than adults, and you really are not giving them any, you are not causing any disadvantage by giving a phakic glass in one eye rather than not prescribing anything at all. Special children are extra special challenges. There is an increasing incidence, ironically, because neonatal care has improved, but not improved as much to give them no morbidities. So while they survive, but they have a lot of times multiple disabilities, cognitive impairment, and difficulty in assessing. And of course, there are very, very few places in India which provide specialized care. They almost always have a cortical visual impairment, and functional visual assessment is again more important than looking for CSM or looking for Snellen's acuity. Certain visual behaviors also can point towards impairment. So as I said, sometimes if the children looks down, probably there may be an altitudinal defect. And here again, a very quick video about a functional visual assessment. You can ask the child, LIA tests are very useful, and you need not ask them to spell it out the card, but ask them to match it. Sometimes that matching helps them orient it much better than actually orally articulating. Especially the high functioning in CVI children often are able to match rather than orally say the number. Again, children who have more severe disabilities often need a functional visual assessment. As I said, this is a small workup of how we deal with these children in clinic. So often if you see, the child is really tends to bang into big things because he has field defect and he has.
I think we could go to the conclusions. Well, Dr. Urmil, your comments before it comes back. No, I have only a small, yeah, go on.
Please, sir, please carry on. I'll say after you.
I have only a small suggestion to go. I don't know how many of you are following that whenever we are operating a child, even if we have been able to do refraction earlier properly, do it under general anesthesia. And I always carried a small portable set, Keeler set for this purpose in the operation theater till my last practice. So that would be a good idea to reconfirm the refraction we have done earlier. Sumita, you have anything else to add further? Because Dr. Chawla, any comments about it?
It was a wonderful talk by Dr. Sumita, sir. And obviously, it is a very tedious job to deal with this special category of children and also the infants. And these small clues which ma'am has mentioned in her talk, the various clues we should be keeping in mind while dealing them. And lot of effort from our staff, from us, has to be taken to elicit their visual acuity properly and follow them with the refractive error and all. So that should be there. Patience on our side is a lot needed.
Recently, sir, I had a very interesting experience. Like Sumita was saying, it is difficult to occlude one eye while doing refraction and the patient is not fixing. So you want to occlude one eye, you know. So I had a very small child, like 2.5-year-old, and he would just not cooperate. So you know, you give them a toy, then they start looking at the toy instead of looking in front. So this incidentally, मुझे पुराना एक अपना रेटिनोस्कोपी मिरर मिल गया, मैंने उसको वो पकड़ा दिया. Just to make him like cooperate a little, and he started doing retinoscopy for me like this, you know. So by asking him to do it with this eye and then with this eye, I was able to have one eye occluded and the other eye straight for refraction.
Dr. Vinita, I had a small toy attachment on my glasses in the center because I had been always using glasses that would make the child look towards my face at least. Of course, you may test the refraction for near, not for distance, but it was quite convenient to do it.
Sir,
So
but if
try
they are
that if you
squinting-
have a toy attached to your center of the
Yes,
glass.
sir, but if they are squinting, you want them to be straight.
Anyhow, it's just a thing. Anyhow, any other comments? Because we are already around 10 minutes late. Dr. Khurana seems to be keen to say something.
Good afternoon, sir. I just want to say happy birthday to you, sir.
Everyone,
I think.
right? Thank you, Dr. Urmil, for
Thank you,
co-chairing
sir.
the session.
Thank you, sir. It's an honor to
And-
share the dice with you.
And Dr. Shreya for
Thank you,
this
sir.
excellent situation.
Thank
See you in the general body meeting next. Of course, I am on the conference. I may interact whenever necessary. Thank you all. Thank
Sorry,
all.
my internet went off for 5 minutes. Thank you. Thank you very
Thank
much
you
for
very
the
much.
opportunity.
It's a wonderful talk, ma'am. Thank you.
Yeah.